Hi, sweeties. How are you doing? Welcome to Naya Sim, and thank you all so much for the love and support. Hope you all are doing great. So, I came across a video where a white woman was talking about maternal mortality, especially when it comes to Black women, and how she, as a doctor or she works in the medical field, so she also noticed that they treat people that look like me differently from how they treat them in medical world, and she also was asking how and all that. The truth is that a majority of the people that are in that medical world, especially, are rate deceased. It is nothing to hide, right? Because I have actually seen so many outbursts from people that are in medical school being rate deceased, or like openly, not just like hiding it. And then in the end, school ends up, like they ended up covering it up, some were expelled, right? And the ones that were not expelled, there are still also people that are in different hospitals doing what they know how to do best, especially when it comes to people that look like me, right? And I am saying this in 2024. I mean, nobody should be discriminated or be treated poorly just because of the way you look. And everybody is supposed to get equal medical care and attention without asking, is this person my kind of person or not my kind of person? All you have to do is do your job diligently and stop acting silly. Let's get into
Anytime that I talk about Black maternal mortality on these interwebs and how we as healthcare providers must treat our Black patients differently, there's always a comment like this. Several, actually. And it can be frustrating. That's not even the right word. I don't even have the right word. It can be, insert whatever I'm feeling right now, to read these comments, because it just proves how much farther we have to go to make sure that Black and brown women are treated based on their risk. Because that's what it is, right? Black and brown women are 4 times, 1, 2, 3, 4, as likely as their white counterparts to have adverse outcomes / death in and around childbirth. So, in seeking to be a bridge, here's what I want to walk through with you. I want to be your gateway drug to wanting to give equitable care. So because you are a nurse, let's walk something out together. Let's say that you are working on a med-surg floor, okay? You've got basic med-surgy type patients, and I give you an admission. And during this admission that I'm giving you, I say, hey, this person is 4 times as likely as all of your other patients to have a heart attack in your care. What are you going to do about that? Would you maybe put them on the monitor? Would you maybe talk to the doctor about drawing some cardiac enzymes? Would you be in more frequently to assess maybe chest pain level or level of consciousness? Would you do those things? Or would you just treat them just like everybody else? It doesn't mean that you're not checking the blood sugar of your diabetic patient. It doesn't mean that you're not measuring the output on your nephrology patient. But it means that you have nursey assessment skills to understand that the risk that someone is carrying around requires different care. And this mentality is just like the all lives matter type of deflection away from the equitable care that our patients need. I give each one of my patients the care that they need and that they deserve. Does it mean that I take care away from the white lady to give to the Black lady? No. This is not a pie, okay? There's no pie involved in this. But just like if I assess with my nursey assessment skills that my patient is wearing a hijab, that tells me, hey, there might be some cultural considerations that I need to go the extra mile for on this person. Is she or is she not comfortable with males in the room? Because I know that there's a male anesthesiologist on today. That might become an issue, so let's talk about it now. If I know that my patient, statistically, is less likely to be believed in a healthcare setting, how is that going to affect my care? If I know that my patient is less likely to have her pain adequately managed, how is that going to affect my care? And if you use your nursing assessment skills to recognize that the color of someone's skin automatically puts them at a higher risk, and that doesn't affect your care, you should not be treating people. Black and brown women are 4 times, 1, 2, 3, 4, as likely as their white counterparts to have adverse outcomes / death in and around childbirth.
What Jen is advocating for is actually the fix to a lot of racial disparities, because the cause of racial disparities is actually not race or anything related to biology, it's racism. Hi, my name is Evan. I'm a bioethicist and I specialize in misinformation, disinformation, and conspiracy theories as a threat to public health. Specifically, one of the areas that I work in is with marginalized and vulnerable populations. And a big misunderstanding in both medicine and public health is that the disparities that occur between racial groups are seen as inherent to biology or to the racial group, when in fact, most of the time, if not all the time, the disparity is related to racism, specifically systemic-based racism. What Jen advocates for in that video is a change to how Black and brown women are treated in the system of maternal care. And that's because the care that they receive and the racism, the inherent racism, systemic racism that occurs means that oftentimes they can lose their life in the simple act of giving birth and for a year or sometimes up to 2 years postpartum. One of the leading causes of this maternal mortality rate is preventable illness, that is preeclampsia and eclampsia. These are just really fancy ways of saying bleeding while giving birth or right before giving birth or soon after, right? And the kind of bleeding that would cause someone to become mortally harmed. We have a substantial number of ways to treat this, but what we would need to do is we would need to pay attention to things like a patient's pain and a patient's symptoms that they self-report often. But there's still an incredible amount of pseudoscientific concepts that are taught when it comes to biology and race, specifically that there are truly biological inherent differences between racial groups. And this is just not true. This concept was coined polygenism. It's a form of eugenics, and it's sort of an ideology as much as it was pseudoscience, or it started off as an ideology that then tried to prove some sort of scientific truth to it, and that was inclusive of or under the concept of eugenics. One of these concepts was the idea that Black women had a shorter gestational cycle, that they biologically had a completely different structure that allowed for them to give birth prematurely more often. This means that doctors frequently didn't see anything wrong with a smaller or premature baby that a Black woman would give birth to, even though oftentimes premature birth is related to things like stress, related to things like social determinants of health, like poverty. It's connected to malnutrition or not eating well or not getting the correct prenatal care. It can be related to trauma. But there's usually something causational that also puts the safety and the health of the infant at risk. Being exposed to cigarette smoking, being exposed to fracking, all of those things can cause someone to give birth prematurely. But if you believe a group of people just naturally has a shorter gestational cycle, then you don't believe these children are premature. Therefore, they are not treated as premature infants, causing a lot of injury or loss of life amongst that population of neonates. Another one that's more well known is that Black people have a higher pain tolerance level or don't feel pain at the same rates that everybody else does. So that when Black people report to have pain, specifically women, that could be actually an indicator of things like preeclampsia or eclampsia, these can often be dismissed. The other thing that can occur is stigma and sort of invented bias around things like opioid addiction and believing that inherently Black women are drug seeking, when in fact they're experiencing true pain. Now, the statistic that Jen cites, the important thing about that statistic is that not only are Black women 4 times as likely to experience a complication that goes uncared for or untaken care of, or causes great damage or distress, or is a threat to their lives, it doesn't matter the age of the Black woman, and it doesn't matter the income level. We see a lot of difference amongst particularly white women if we change their socioeconomic status and if we change their age. But for Black women, it doesn't change enough to be to have the same impression, which means it's related to something systemic. It's related to not getting an exceptional amount of care or not having their needs believed. Combining gen statistic with the fact that 39 to 56% of Black newborns thrive much better under a Black physician lets you know that what the issue is related to something systemic and racist, not racial. We see this conflation all the time in public health, that a disparity between racial groups indicates something related to racial groups, when in fact it's related to racism against particular groups. Black and brown people don't have lower life expectancies because of their Black or brownness. Black and brown people have lower life expectancies because of systemic factors in their environments or their experiences that put them at higher risk of losing their lives younger. In Philadelphia, downtown Philadelphia, specifically Society Hill, is about 5 miles away from East Germantown and North Philly. In Society Hill, the average life expectancy is somewhere around 83 years old. But a 15-minute drive or a 10-minute ride on the regional rail, or like a 30-minute ride on the bus, you go up to North Philly and East Germantown, the life expectancy plummets to somewhere around 65 years old. Same city, 15 minutes apart. Why is that? The reason is because of things like redlining and the way that resources are distributed and environmental pollutants. The areas around places like North Philly and East Germantown experience a lot less community investment and experience a lot more community pollutants and environmental pollutants than areas like Society Hill. And these are controllable factors by good governance, by investing in neighborhoods, but they're not done. And they're not done, number one, because one neighborhood is predominantly white and affluent, and another neighborhood is predominantly Black and working class or poor. Affluence and socioeconomic status, combined with the beliefs, the long-standing beliefs that race is inherently biological and that these disparities are caused by people's race, has meant that we've spent an inordinate amount of time putting public health resources into the community instead of into redesigning, rebuilding, or dismantling components of the system. So doing things like trying to bring fresh foods into certain neighborhoods, which is a good thing, but not thinking about how for many of the people in that population of that neighborhood, fresh foods might be within their reach if they were affordable. Or fresh foods might be available to them, or they might consume them if they were taught from their healthcare provider, or if their healthcare provider told them that they were pre-diabetic or pre-hypertensive, rather than waiting till they were very, very sick to then try to teach them about healthy eating or exercise or engagement. And just to understand that this design of discrimination and systemic discrimination being the cause of a lot of what creates health disparities goes beyond things like race, although race compounds all of them. But even with folks who have disabilities, for example, a lot of times their disability isn't the thing that necessarily keeps them from being able to access a lot. It's the fact that our world isn't adapted to let a multitude of people access what they need to access. It's not frequently someone's ambulatory-based disability that gets in the way of them being able to access things. It's the fact that we've designed urban space to not be inclusive or not be able to be traversed by wheelchairs, crutches, walkers, and any other sort of assistive devices. And even when we do make places adaptable or inclusive, we limit the amount of adaptation that we're allowing, like 2 wheelchairs on a bus. But what if 4 people want to go to lunch? For those people that work in medicine and public health, I would encourage you to stop thinking about How can I get this racial group to make these changes? And before you start to engage that population, ask yourself, is there something systemically that I can do I can dismantle that would make this change even easier or more plausible? So when Jen says in her video to treat people differently, because we now know this thing, that's what you want to do, is treat them differently by not discriminating or continuing to perpetuate pseudoscientific bias.
To understand that the risk that someone is carrying around.
Okay, this is I love the point of this video and stuff, but I'm realizing, like, I've had conversations on my Patreon recently about this, and I think this line of thinking is where the information does not translate in like a humanized way, right? Like the 4 times adverse impact, like, we aren't carrying the risk. Yes, epigenetics and stuff impacts our bodies, but like the risk is that we are interacting with people that don't believe us, that think we yell louder, that read the books. Like, it's the books that tell you we don't know our own pain levels. So when you're saying they're at risk, like we're at risk, it's of interacting with harmful healthcare workers. It's not that we walk, like, if healthcare was not based in racism, we wouldn't be carrying around the risk, right? So like, I just want to center where the harm is, who is harmed and how. And it's not that we just walk around like it's not like, oh, we're more likely to experience a heart attack. We're more likely to end up in a place where no one thinks we are at risk for one. So when it happens, everyone is shocked and no one's prepared and no one believes for a long time. And then boom, you know what I'm saying? So it's like, what you should be doing is watching your coworkers more. You should be talking more to your coworkers, not paying special attention to the Black people necessarily. I don't think it's wrong. I just think the harm isn't coming from within Blackness. And I think that's kind of the message that gets spread with the whole 3 times, 4 times more likely to experience bad stuff from white people. I think we miss, like, the silent part of racism is that it's silently in there. You got to find it. That's the problem. It's not the Blackness. Blackness doesn't increase our risk. Blackness around white people and white systems designed to oppress us put us at risk. That's why, like, during segregation, when we had all Black teachers, let's just deal with this first. Check out my Patreon. I know Jen doesn't follow me, so like it kind of almost like reinforces just like my own thing. Check me out. Places.
This is all I got from this video, and it's very, very enlightening. I love it. And the truth is that I really do not understand or know where most of the things they say about Black people, or like, the risk isn't being Black according to the other one. The truth is that I don't know, but like, some of them do not feel like Black people deserve anything. Like, we do not deserve to be treated equally as them, or, a group is better, like, superior than the other one and shouldn't get equal treatment and all that, because I do not understand how maternal mortality in 2024 will still be something that Black people are still talking about, because this is not supposed to be existing, sincerely speaking. No woman deserves to die or go through, like, a lot of pain aside from the natural pain. They are, like, they experience being a mother, and someone else is somewhere also trying to add to the pains that they go through. This is how I feel it, because I do not know how you are a medical practitioner and you are supposed to help lessen my burden during probably childbirth or something, but you are making it harder for me by not providing or giving me the adequate care that I am supposed to receive, right? Now, let's look at this from this angle, because some certain things sometimes it looks like it's unreal and some things are like, but then it is true. And it's really amazing how a lot of people were not able to understand what Black women go through. I love the fact that like we have internet everywhere right now. People can easily Google some certain things. People can also do their own research, speak to other people about it, and all that. And also, the good part is that Black women or Black people in general are not quiet. They are not the people that will tell you that it is not in their culture to keep quiet. Because if you were in their culture to keep quiet, all this wouldn't be out there. But they have seen how they have been treated so far and decided that this is not what we are going to keep quiet, and they keep screaming and talking about it. Because I do not, but sincerely speaking, majority of all these people, like, sometimes you see them being rich disease on the internet and all that, and then boom, you come out and you see that the same person that was very, very rich disease is now a nurse. A nurse. And I have also seen some of them in medical school coming out to say so many denigrating things about Black people. And probably that day might not be their lucky days. Probably they went out, they get drunk, and they come out and they started speaking some racist rhetoric and all that. I can remember from last year to this very moment about so many students that are already know like it though. They expelled them from school. Some schools sealed some of it up, right? But majority of them are nurses. And then how do you expect people that spew some rare disease rhetoric about people that look like me to treat me nicely? So all these are the things also medical schools, nurses, doctors are also supposed to look into, check their also background, because sometimes there is no smoke without fire, Let's also start tracing back the people that we bring into places. Like people that are serving community or are rendering services to people. Because in the end, they come into a space and they do not want to do their job when they see people like me. If they are supposed to do A, they do C, making it hard for people that look like me. All these it's super real. Maternal mortality is real, not just only that, other places. They also believe that we don't feel pain like they do. And I remember, thank God also, I love the fact that people are also creating awareness, because even I remember an African woman, she's a nurse, right? She is working in UK. And she was, there is a video, she said it, but it was with no sound, but you could see the things writing and all that. She said, as a Black woman, you go to the doctor in UK and the first thing they will get, like, you have pneumonia, paracetamol, that is Tylenol in yours. You have pains, paracetamol. You have this, paracetamol. You have toothache, paracetamol. Why? Because they don't want to check what is going on with you. They just give you paracetamol because paracetamol is the cure to everything. What a shame. See you all in my next video. Bye for now.